Welcome to this webinar on conquering therapeutic challenges in subependymal giant cell astrocytoma associated with tuberous sclerosis complex. Today we'll be talking about the power of mTOR inhibition. My name is Bruce Korf. I'm professor and chair of the Department of Genetics at University of Alabama at Birmingham, and our co-speaker is Darcy Kruger, associate professor at Cincinnati Children's Hospital Medical Center in Cincinnati, Ohio. Here are our disclaimers. Realize the possibility of unlabeled use being discussed in the context of this presentation. And these are the conflicts of interest for myself and also for Dr. Kruger. I'll provide a brief overview of tuberous sclerosis complex in just a few moments and then talk about the genetics. And then Dr. Kruger will specifically focus on the management of subependymal giant cell astrocytoma. We'll then conclude with a set of cases to illustrate the application of treatments in subependymal giant cell astrocytoma, and then finally conclude the presentation with some remarks by each of us. These are the learning objectives. I won't read them all to you, but fundamentally we're looking to set the stage, to understand the need for treatment, the pathogenesis, and then the rationale for the use of mTOR inhibition in the treatment of tuberous sclerosis complex. So let me begin with an overview of the clinical entity. Tuberous sclerosis complex has an incidence of about 1 in 6,000 newborns across the entire world. There do not seem to be populations that have particularly high, or for that matter, particularly low frequencies of the condition. And in part, this is explained by the fact that about 50% of cases are due to new mutation, 50% or more, which means that a genetic alteration occurs to cause the condition in a child that was not present in either parent. And these mutations can occur really anywhere in the world to any individual. The genetics are that of autosomal dominant transmission. I'll explain a bit more about that in a few moments. This is a disorder in which there is complete penetrance. That means that all individuals who carry a pathological mutation in either of the two genes, as you will see, that are responsible for this condition can be expected to show signs of the condition. This is not a condition that an individual can have the gene mutation and have it not be expressed or to be silent in that person. That being said, this also is a condition associated with highly variable expression, which means that the severity of the condition, the specific manifestations, and even the age of onset can differ from one person to another, sometimes even within the same family. The diagnosis of tuberous sclerosis complex is established clinically, and a set of diagnostic criteria have been set forward. The criteria are divided into major and minor criteria. Major criteria are features that are very distinctive and characteristic of tuberous sclerosis complex, and their presence is a very strong indicator of the likelihood of an individual being affected. The minor criteria are somewhat less specific and therefore helpful in establishing a diagnosis, but perhaps less so than the major criteria. Now, I'm not going to read all of these to you because you'll be seeing examples of these in just a few moments, but I will say that a definitive diagnosis of tuberous sclerosis complex can be established in an individual who has two major criteria or one major criterion and two or more minor ones. And then we also recognize a possible diagnosis of tuberous sclerosis complex in an individual with a single major or two or more minor criteria. Here are many of the skin lesions associated with tuberous sclerosis complex, and often these are the first sign that suggests that an individual might be affected. On the left, you see hypomelanotic macules which are very commonly seen in individuals with this condition and will have onset in infancy. They're quite dramatically illustrated in this child, but in a child who is very fair-skinned, they may not be so easy to see, and often will require the use of the Woods lamp, which is a blue lamp that is used in a otherwise totally darkened room to enhance the contrast. Now, it is possible to have other kinds of hypopigmented macules that are not the typical ones of tuberous sclerosis, which is why these by themselves are not pathognomonic for the disorder, but they are a very helpful sign present in most, as you see, not quite all affected individuals. The second feature is the shagreen patch, which, as you see, is present in about half of affected individuals. It is usually seen on the back, especially in the lower back and the flank region. It has its onset in early childhood, not typically in infancy, and represents a kind of connective tissue dysplasia in the skin, which can be highly characteristic of tuberous sclerosis complex. Many individuals, as you see, about 25% exhibit forehead plaques, which are collagenous plaques that are commonly seen in the forehead, actually can be seen elsewhere on the body as well. Angiofibroma is a characteristic facial lesion, usually in the face. There are instances where it might occur elsewhere, but very typically on the nose and on the cheeks. It appears, as you see, between about 2 and 5 years of age. Often is confused with acne, but does not involve skin pores like acne does, and consists of connective tissue and blood vessels. And then finally, ungual fibromas. The illustration here shows one on a fingernail. They're actually a bit more common on the toenails than fingernails. They can be embedded within the nail bed, under it, or on top of it, can cause splitting and a sort of distortion of the nail in a kind of longitudinal pattern. This slide illustrates some of the characteristic central nervous system lesions one sees in tuberous sclerosis complex. On the upper left, cortical dysplasia, which really is what gives the condition its name, the idea of tuber, a swelling in the cortex of the brain, was one of the first known pathological signs and is certainly associated with some of the underlying clinical pathology in terms of both epilepsy and intellectual disability. The middle photomicrograph shows a close-up of a abnormal region in cortex on the left compared to normal cortex on the right. One of the things characteristically seen are giant cells that actually have staining characteristics that are sort of overlapping between glial cells and neurons. And on the right, you see a magnetic resonance imaging view that illustrates in the bright areas some of the cortical dysplasias as they would appear in an imaging study. On the bottom, you see subependymal nodules that are common in individuals with tuberous sclerosis complex. The pathology picture on the left shows the irregularity in the lateral borders of the lateral ventricles. And then on the right is a computed tomography scan showing the calcification of the subependymal nodules, which is characteristic. From a clinical point of view, the most common and probably most severe early manifestation is the occurrence of seizures. And this is a data set from a study published now 20 years ago that illustrates the onset of seizures. You see that a high proportion of individuals who develop seizures did so within the first year of life, although there is a small proportion of individuals whose seizures might have occurred in adulthood. In this study, seizures occurred at some point in 78% of individuals. You realize, of course, that there's some bias of ascertainment here. This is probably how the diagnosis came to attention in many of those individuals. But without question, epilepsy is one of the common and potentially serious manifestations of tuberous sclerosis complex. The other neuropsychiatric issue are the TSC-associated neuropsychiatric disorders, sometimes referred to by the acronym TAND. These include things such as aggressive behavior, autism spectrum disorders, intellectual disability, psychiatric disorders, and neuropsychological deficits. And the table at the right comes from the same paper about 20 years ago, and you can see that intellectual disability, when it occurred, had early onset, usually in the early years of life. There were a smaller proportion of individuals found to have intellectual disability in older age groups, which again probably represents some degree of bias of ascertainment. One of the most important points is the relationship between epilepsy and intellectual outcome. Once again, from this study a while back, you'll notice that the highest prevalence of learning disorder occurred in individuals whose seizures occurred in the first 2 years of life. And it was much less typical to have significant intellectual disability when seizures occurred later in life. Furthermore, the most ominous pattern of seizures occurring early on is that of infantile spasms, where there was a very high proportion of intellectual disability. Seizure control, in many of the instances, realized this was 20-odd years ago, and seizure medications have evolved a great deal in that time, but in many cases was not good. And there is a pretty well-established relationship between seizure control and intellectual outcome. Probably the most important message is the critical importance of being alert to the occurrence of seizures early in life and aggressive in the efforts to treat these, because early and aggressive treatment can make a big difference in terms of intellectual outcome. Now, staying within the context of the central nervous system, and it is the major focus of today's talk, is subependymal giant cell astrocytoma, illustrated by the bright area at the foramen of Monroe in this MRI scan that you're looking at. The frequency in tuberous sclerosis complex, as you see, is in the 5 to 15% range. And in those who become symptomatic, as this grows, the signs and symptoms are those of hydrocephalus, exacerbation of seizures, and potentially a focal neurological deficit. Of course, the main goal, as you'll hear as we go forward, is to proactively treat these to avoid complications, especially ones like hydrocephalus. Now, beyond the nervous system, there are many manifestations that both are important diagnostically and in terms of management. This is a photograph of a glial nodule, a so-called retinal hamartoma, in the back of the eye that you will see in 30 to 50% of individuals with tuberous sclerosis complex. In spite of their ominous appearance, in fact, they're usually asymptomatic and probably more important as a diagnostic marker than as a problem that needs treatment. And the other ophthalmological feature would be the retinal achromic patches that may occur. Tuberous sclerosis complex has important effects on the kidney, particularly the occurrence of angiomyolipoma that occurs in upwards of 80% of patients, and then also some with multiple renal cysts. Cardiac rhabdomyoma is an important manifestation that occurs in about 50%, but has an unusual natural history compared with practically anything else in tuberous sclerosis complex, in that the cardiac tumors tend to regress spontaneously, most frequently found in the ventricular septum, and most of the time are asymptomatic, but they can cause heart failure or interfere with cardiac conduction, and in fact have been used as a basis for ultrasound prenatal diagnosis. In the lung, there is a complication called lymphangioliomyomatosis, which typically occurs in females with tuberous sclerosis complex who are over 18 years of age. The frequency can be significant, as you can see, by age 40, and it can have very profound effects on pulmonary function, leading in some to even respiratory failure. The evaluation for this would include pulmonary function tests, 6-minute walk test looking for signs of dyspnea, high-resolution chest CT, and serum VEGF values can actually also be used as an indicator of this condition. There are many other clinical features of tuberous sclerosis complex, some of which are listed here: confetti skin lesions, scattered, very small punctate hypopigmented lesions on the skin. Dental enamel pits can occur, gingival fibromas on the gums, bone cysts. Another lung, or actually two other lung conditions, micronodular pneumocyte hyperplasia, and even clear cell tumor of the lung. So how does one actually follow an individual with tuberous sclerosis complex? This is a set of guidelines put together by a consensus expert group now a couple of years ago, recommending, first of all, with regard to the central nervous system, that MRI be done every 1 to 3 years, depending, of course, on the findings, particularly with focus on the ventricular system with concern about the possibility of subependymal giant cell astrocytoma. EEG as a baseline and as needed, depending on clinical features, being vigilant to the possibility of seizures, because again, need to stress the importance of proactive treatment of epilepsy, and developmental screening to identify various of the neurodevelopmental features that we spoke about. With regard to the kidney, an MRI of the abdomen, again, repeated every 1 to 3 years, depending on what's found. In individuals who have lesions, the frequency might be greater. In those that don't, one might not need to do it as often. Monitoring blood pressure, because the kidney lesions can manifest as hypertension, and checking glomerular filtration rate on an annual basis as a measure of kidney function. We mentioned the pulmonary manifestations, and this is mainly true in adult females with tuberous sclerosis complex, doing baseline pulmonary function and walk test, and then high-resolution chest CT, and repeating that every 5 to 10 years, depending on symptoms and also depending on previous findings. An annual ophthalmologic assessment. The cardiac manifestations, as I mentioned earlier, are more characteristic in children than adults. Echocardiography in children, probably that won't be very valuable in adults, but to do an electrocardiogram, because there can be ECG changes that may be the sort of long-term sequela of a previous rhabdomyoma. A skin exam on a regular basis, and dental monitoring given the occurrence of pits. So let me now make some comments about the genetics of tuberous sclerosis complex. There are 2 distinct genes that have been identified, mutations in either one of which will cause fundamentally the same disorder. One of these, referred to as TSC1, encodes a protein called hamartin, is located on chromosome 9, and the other gene, TSC2, encodes tuberin, and the gene maps to chromosome 16. Now, individuals with tuberous sclerosis complex will have a mutation either in TSC1 or in TSC2, and generally not both. Tuberous sclerosis complex is an example of classic autosomal dominant inheritance, where an affected individual has a 50% chance of transmitting the trait to any offspring. Males can transmit to sons or daughters, and females can transmit to sons and daughters. And in general, tuberous sclerosis complex does not skip generations, so it's unlikely you'll find unaffected individuals who have affected parents and affected children. Now, because, as I mentioned earlier, this is a condition subject to widely variable expression, you'll certainly find individuals who are more obviously affected and some who are less obviously affected within the family. And one needs to be very careful in examining the parents of a child affected, because they may have only subtle findings. Some hypopigmented macules they may never have really paid attention to. They could have brain or kidney lesions they were previously unaware of, or eye lesions. And so one needs to examine both parents carefully, looking for signs, and that can include imaging of the brain, imaging of the kidney, an eye exam, and a skin exam. But with all that said, 50 or more % of cases occur due to new mutation, like is shown on the right, where two healthy parents with truly no signs have had an affected child due to a new mutation in the sperm cell or egg cell that formed that child. And in those instances, the parents have a very low risk of having another affected child, although there is some risk based on the possibility of germline mosaicism, where the parents may have another sperm or another egg cell also with the mutation, even though somatic cells do not express it. However, once a child has tuberous sclerosis complex due to new mutation, as that child grows up, he or she will face a 50-50 chance of transmission to the next generation. Now, we have learned that a substantial number of individuals who are the founding affected member of their family are mosaics. A mosaic is an individual who is literally a mixture of cells with or without a mutation. And that happens when early in development, a mutation occurred in one cell, and the descendants of that cell then share that mutation, but other cells don't. If that occurs in somatic tissue, an individual can have some signs of tuberous sclerosis complex, possibly milder because fewer cells are affected, but not necessarily, because it could actually involve critical cells, let's say in the brain, and they may have significant neurologic problems. It could also be confined just to the germline, as I mentioned a few moments ago, and only manifest as a healthy parent having more than one affected child. Now, genetic testing is available as a tool for diagnosis of tuberous sclerosis complex. It's done by DNA testing. And the reason why to do it, first of all, would be to confirm a suspected clinical diagnosis and also to serve as a basis for genetic counseling. Once the gene is known, the gene mutation is known in a given individual, other individuals potentially at risk based on family history can be offered testing and definitively told whether they do or don't carry that same mutation. That could be siblings or even extended family members. One does need to be cautious if you test both parents and they are not found to have a mutation that their child has. Although it indicates the child has a new mutation, it does not rule out the possibility that one of the parents has mosaicism or germline mosaicism. As mentioned, there are two different genes, TSC1 and TSC2, and it's not easy to look at an individual and predict in advance which of the two would harbor a mutation. So generally both are tested. Current technology has about an 80% sensitivity. So that means there are a substantial number of individuals who really do have the condition, and yet one cannot find a TSC1 or 2 mutation. Many of these, we believe, are due to mosaicism. And since blood is the typical tissue used for genetic testing, if blood cells happen not to be among those that carry the mutation, the genetic testing would be negative. There actually are some new technologies that are now beginning to be applied that may have greater sensitivity and might pick up a higher proportion of mutations. This is a diagram of the chromosome location of the TSC1 gene on chromosome 9 and the TSC2 gene on chromosome 16. And one reason to show it is you'll notice on chromosome 16 that very near the TSC2 gene is the PKD1 gene. PKD stands for adult polycystic kidney disease. And there are some individuals with tuberous sclerosis complex who have a gene deletion, or a chromosomal deletion actually, that spans the TSC2 and the nearby PKD1 gene. And they literally have two genetic disorders, TSC due to TSC2 deletion and polycystic kidney disease due to PKD1 deletion. So they will have the classic signs of polycystic kidney disease in addition to their tuberous sclerosis complex. So it was mentioned that there are two genes that encode two distinct proteins. The question might come up, so why is it that a mutation in either one of these two genes gives fundamentally the same phenotype? And the answer turns out to be that hamartin and tuberin actually associate together to form a complex. And when there is a mutation in the genes coding either one of these, that is sufficient to disrupt the function of the complex. And so it doesn't matter whether the mutation is in TSC1 or TSC2. And the mechanism that has been elucidated by study of the biological pathway now is going to be very important, as you'll hear more in a few minutes about treatment, because this hamartin-tuberin complex inhibits a protein called Rheb, and Rheb in turn stimulates a protein called mTOR, which is a kind of almost master switch that is involved in regulation of cell growth and proliferation. When the hamartin-tuberin complex is disrupted because of mutation, Rheb is disinhibited, and that allows it to stimulate mTOR. And the bottom line is you have too much mTOR signaling as a consequence of the deficiency in the hamartin-tuberin complex. Well, with that introduction to the clinical features and genetics, I'd like to turn now the presentation over to Dr. Kruger, who will talk specifically about the subependymal giant cell astrocytomas. Darcy?
Thank you, Bruce. A very nice overview of TSC and the genetics and the molecular biology behind that. And so it's my pleasure now to talk about specifically the subependymal giant cell astrocytomas, the tumors in the brain, and some of the clinical management issues that surround SEGA, and the opportunity we have to treat those now with pharmacological inhibitors of mTOR. Just to remind again that SEGA are just one aspect of the brain involvement in TSC. And we see examples here on MRI of the cortical dysplasias that occur in TSC, which we often have what tuberous sclerosis is named for, the tubers, as well as what historically has been called radial migration lines, which are still just another form of cortical dysplasia that is spread out as the cells migrate across the brain during its initial development. The subependymal nodules are important as well because these are the precursors to what SEGAs become. Many times I'm asked, well, what is the difference between a SEGA and a subependymal nodule? And on a histological basis, they are practically identical. The cellular structures look the same, but for reasons we yet have not fully identified, in a small percentage of patients, these will suddenly start growing predominantly in childhood. And when they start to grow, it is that evidence of growth that causes us to name them differently and call them now a SEGA instead of a subependymal nodule. Here is an example of a SEGA, or subependymal giant cell astrocytoma, in one of our patients. And what you see is a typical scenario where early on in life, in childhood, you see that a nodule is beginning to grow, and then over the course of, in this case, a little bit over a year, you see that there's no question that this nodule has grown serially, and at this point has met the definition of SEGA. Other people have tried to use definitions such as a minimum size of a nodule, but we know that some nodules can be quite large but not show any evidence of growth, particularly ones that have lots of calcium inside in them. And then also we know that some patients who have never previously had a SEGA or nodule that was identified in MRI, and on a follow-up imaging suddenly see something that was clearly not there previously, we would use this as evidence of a SEGA as well for animal growth. And finally, others have tried to say, well, does it take up contrast? And a contrast uptake in a lesion in the subependymal zone would be a SEGA. The truth is that subependymal nodules very much take up contrast as well. And so really the only diagnostic criteria that has been applied and universally accepted is that there is growth based on multiple imaging studies over time. These typically are slow growing, but we do have sometimes situations where they may appear within 6 to 12 months after previous imaging. So that's where the recommendations come in. We'll come back to these towards the end of having a range of when imaging might need to be repeated between 1 to 3 years, depending on symptoms, depending on whether a lesion is already previously suspected and has been followed over time. Determines on whether that follow-up imaging needs to occur. Now, as you'll see, when Dr. Korf was presenting, he quoted that the prevalence of SEGA in tuberous sclerosis, it ranges between 5 and 15%. And that is because that range arise from what was shown in here in this table of various studies that have been done over the past 20 to 30 years, all coming up with different estimates of what the true prevalence is. Now, this variation likely comes from differences in how these studies were performed, as well as the time that they were done, and as well as the number of patients that they were able to include in their estimates for prevalence. For example, some studies only counted patients who went to surgery and had a pathological confirmation of the lesion being a SEGA, versus other studies were willing to accept imaging evidence of growth as a criteria for including the diagnosis of SEGA. Others as well that might have been done 20, 30 years ago before the modern era of imaging often depended on patients to present with symptoms in order to have the diagnosis made and therefore proceed to surgery and have the diagnosis confirmed. All of these combined mean that we have this wide range, and if you took all the studies that have ever been done, regardless of the methodology, the estimate works out to be about 10 to 11%. But if you look at those that have done more in the modern era and that have used imaging and surveillance as the criteria, it works out roughly to about 16% or a little bit on that higher side of that range. Most clinicians today will typically quote somewhere between 10 and 15% as the most likely prevalence of SEGA. Now, we worry about SEGA not because it has high malignant potential. In fact, there are a few case reports in the literature of malignancy in association with a patient that had a previous diagnosis of SEGA. Some of those are associated with patients that received radiation therapy, which is generally not a recommended course of action today. But nonetheless, these are considered benign tumors. The problem clinically arises from their propensity to grow near the foramen Monroe in the center of the brain. And this foramen is bilaterally is critical for how fluid that is created by the brain must flow and exit the brain. And if it is blocked, you have symptoms of hydrocephalus. What you'll see here shown can start with very incidental or very minimal type symptoms that overlap with the typical symptoms we see in TSC, such as irritability or an increase in seizures that may not be obviously attributable to hydrocephalus being caused by SEGA. This can progress to headaches and vomiting, but particularly if a child is developmentally disabled and not able to express themselves, this can be hard to perceive as well on the part of the parent or the clinician. But certainly by the time when we see ataxia, vision disturbances, and decreased mental status, then it's obvious that something bad is going on, and certainly SEGA should be considered in a child with TSC. Or even with an adult with TSC that doesn't have explained reason for a change in mental status or behavior. Ultimately, if these are unaddressed medically or surgically, these patients run a risk of acute obstruction and death as a result of SEGA. So it's in this context that SEGA are not just a nuisance, but they actually have clinical relevance despite their very low malignancy potential. Historically, these have been treated surgically, and here is a slide that just shows how today surgical treatment has advanced to the point where SEGA surgery is a viable and very effective treatment option, and we'll talk about that in the next slide, where we can use modern stereotactic techniques to identify the approach of the that we can identify the approach for the tumor and make sure that there is a complete resection. It's generally accepted that if there is an incomplete resection of the SEGA tumor, the residual tissue will continue to grow, and the child or adult will require a repeat surgery or other treatment in order to address the SEGA definitively. But not all SEGAs are successful. And here's an example of a patient where the tumor was operated on, but there was residual tissue that was left behind, and this residual tissue within 3 months had showed dramatic increase in growth. And also, in addition to this, you can have complications associated with persistent hydrocephalus. It is quite common that children with SEGA require shunting either before or even after the tumor has been removed due to persistent obstruction of the foramen Monroe. You can have bleeding associated with surgery. These tumors are highly vascular. They also are located very proximal to deep veins of the within the brain, and so that hemorrhage complications are certainly reported in patients that have had surgery for their SEGA. Infections and neurological injuries and even death have been reported in various case series associated with surgery in TSC. And here's a summary of all the studies that have been published to date for SEGA. And when we look at these in a pooled analysis comparing favorable outcome, which means no recurrence or complication, the overall success rate is about 68%. And this is lower than what most people would quote in today's world, because this includes surgeries that occurred 20 or 30 years ago, and certainly, as I mentioned, surgical techniques and approaches and surgeon expertise has advanced dramatically in that time frame. However, even if we look at those that have been done in the last 20 years, when we have the advent of modern imaging and microsurgery, the calculated success rate for no recurrence and no complication is still roughly about 80%. So the question arises, is that good enough, or can we have alternative treatments available that would be comparable to this or maybe even superior to this, the risk associated with incomplete surgery and recurrence, or to have other complications? The reality is it's very hard to compare these two together, but I'll show a slide at the very end on at least a cursory attempt that we made to ask this question when we talk about medical therapy versus surgical therapy. Now, as Dr. Korf mentioned, we understand in large ways on how TSC occurs at the molecular level. This understanding that we present to you today is understandably simplified to show critically on how the role of mTOR inhibitors can be used for the treatment of SEGA. And there's lots of feedback and crosstalk molecular pathways and signaling pathways that are certainly important, as well as downstream effects of mTOR that can be differentiated and possibly even target selectively to treat specific aspects of TSC. What I show here is the situation that we have. In the first panel, you see what is the normal condition that Dr. Korf showed. And what we see when Hamerton or tuberin are not functional, we see that mTOR activity is allowed to proceed unchecked. And therefore, you have unregulated growth and proliferation that leads to tumors like SEGA. Now, what we can use is mTOR inhibitors such as sirolimus or everolimus. Everolimus is FDA and EMA approved for treatment of subependymal giant astrocytoma and TSC, and it's also approved for renal angiomyolipomas. And sirolimus is FDA approved for treatment of lymphangioliomatosis in TSC. And we can treat patients with TSC with everolimus and similar mTOR inhibitors and block this upregulated state of mTOR that occurs in TSC that should not be present. The two mTOR inhibitors that we use, as I mentioned, that are approved in TSC are everolimus and sirolimus. They have very similar molecular structures, and they both are very effective inhibitors on the pharmacological level of mTOR, and particularly the complex of mTOR that's important for many of the manifestations of TSC that we've been talking about, which is called mTOR complex 1 or TORC1. And as I mentioned, SEGA was approved indication for everolimus in 2010. Angiolipoma was approved indication for 2012. And then most recently, LAM, or lymphangioliomatosis, got FDA approval for sirolimus in 2015. These have a variety of brand names that under which they're marketed, and they're both oral medications that are taken typically once a day. They have similar protein binding, but they are not identical, and they do differ significantly in their half-life, and this largely results in difference in how much the oral dose is for one medication versus the other, but otherwise they're metabolized very similarly as well. What this means is that, as you can see, the two different compounds have been approved for different indications based on their clinical development. So what I want to spend the remainder of my time is talking about the clinical trials that have led to particularly approval of everolimus for treatment of SEGA, and talk a little bit about the side effects that emerged from those clinical trials. And then again have a discussion of how these fit in with the clinical recommendations by the 2012 TSC consensus group, as well as how their role fits in with the context of surgical resection of SEGA. So the first trial I'm going to talk about is a phase 1, phase 2 open label clinical trial in which 28 patients were treated with everolimus, and their initial response was evaluated after 6 months, and then treatment was continued for an additional 5 years. This was recently, the 5-year analysis was recently completed and published and is now available. What we see here is the initial response shown in these patients over time, and in the left graphic you see that very quickly it becomes evident in the majority of patients of how much they will respond to treatment. This is the absolute change in volume on the left, and you see within 3 to 6 months most of the response that's going to be achieved is evident. It doesn't mean to say that all the response is evident, and then we certainly do see patients, and you see here that even from 6 months to 48 months, that there are some patients that will continue to show a modest further decrease in SEGA volume with treatment. You also see that there is some variation over time as the patients continue treatment, and this likely reflects partly variations in imaging sensitivity, as well as that some patients are able to stay on medicine continuously without any major side effects that causes disruption in treatment, versus some patients may have treatment disrupted for a week or a few weeks at a time, and this may factor in as well. But what we don't see is reoccurrence of SEGA growth after initial response has been demonstrated in almost essentially every patient that has shown a response. On the right is showing, again, the similar phenomenon, breaking up between what's shown in dark is a greater than 50% reduction, and the light blue is showing a 30% reduction in patients over time. And also shows that the percentage decrease. As you'll notice, none of these go to 100%. So this is one clear distinction between what surgery has the potential to offer a patient compared to medication therapy, which is medication therapy reduces the SEGA but does not make it fully go away. And versus surgical resection, if a complete resection is achieved, has 100% removal of the SEGA. So this is a clear difference between the two therapeutic options. But by and by, it shows that a vast majority of patients show a 50% reduction or at least a 30% reduction after starting treatment, and that is sustained over time. This was followed up by a phase 3 clinical trial, which included placebo and double blinding, as well as randomization into 2 treatment groups, those that were treated with everolimus and those that received a placebo. Randomization was 2-to-1, meaning that for every 2 patients that received medication, 1 patient received placebo. Is shown here is the criteria that were used for the study that is similar to what I told you before that many people have used for defining what a SEGA is. It's important to make the distinction that this is how it was defined for a clinical trial, but that doesn't necessarily how it's defined clinically. And again, the only clinical criteria that is universally accepted is evidence of growth on serial imaging. So we had a total of 17 patients enrolled in this clinical trial within the 2 groups. And here you see an example of one of the patients that participated in this clinical trial. This is shown at the top. You see coronal MRI images with contrast. And on the bottom, you see the corresponding axial images for that same level. And what you can see that at 6 months, there is a 50% reduction in this patient, 51% to be exact. And then at 54 months, which is the last time point where we have imaging for this patient in the study, that the reduction was 62%. Again, highlighting the fact that there can be continued reduction beyond the first 6 months, but in most patients, you're going to see the greatest reduction within those first 6 months of treatment. Here we see the analysis from which this patient belongs for the entire treatment groups. And you see that for those patients that were treated with everolimus, the reduction was around 40% at 3 months and almost 50% at 6 months. And this is in contrast to those in the placebo group that continue to show growth, not reduction, over those same time intervals. And this is demonstrated graphically below the table for the 2 treatment groups. On the left, you see actual progression, meaning that there was actual increased growth, and these patients that showed increased growth were unblinded and could, if they were in the placebo group, start treatment. And we see that that happened in 6 patients. There were no patients that showed growth in the treatment group, and therefore none of those were unblinded. And we found out after the trial was completed that that was the case. With any medical therapy, I already talked, or even surgical therapy, I told you about what it can do, and I told you what the risks or the concerns of where it falls short. And that's true for medication treatment of SEGA as well. And for an everolimus in the long-term study, we see side effects with treatment. The most common were mouth sores, which can be classified in a severe state of stomatitis, as well as mouth sores. And these occur roughly in about half patients that are treated with everolimus. Most of these are considered mild and don't cause a significant disruption in treatment, and there are also symptomatic treatments that can be used in order to limit the severity and or frequency of mouth sores with treatment of mTOR inhibitors. The other major side effect that we tend to see that is treatment-related and shown in yellow here is increased cholesterol and occasionally increased triglycerides, but particularly cholesterol. This largely probably has to do with how the everolimus is metabolized and how it interacts with HMG-CoA reductase, which is important in cholesterol manufacture and production within the body. Again, these tend to be fairly mild elevations and don't require any specific intervention, but in those patients where it is concerning, these can be managed symptomatically. There's a variety of other side effects that have been reported in clinical trials of everolimus, particularly infections of various types. It's important to know that the rate of infections, and the reason why they're not highlighted here, are roughly equal or higher in the placebo groups in the various trials that have been done with placebo controls. So even though mTOR inhibitors do have some immunosuppressive properties, and we do appropriately take those in consideration in how we manage children and adults who are treated with mTOR inhibitors, it should be noted that the actual frequency and severity of infections in the placebo-controlled trials was comparable between both those who were treated with everolimus and those who received placebo. The other phenomenon you see here demonstrated in the graph on the right is that as everolimus treatment is continued over time, is that the rate of adverse events or side effects tends to go down year by year as patients continue therapy. So there doesn't seem to be a cumulative toxicity over time or a reduced tolerance of treatment over time. Rather, it's quite the opposite. So the question arises, okay, we have effective surgery for many of the patients. We have effective medication treatment for many patients. What should we do when we have a patient who has arrived to the point where we make the diagnosis that they have a subependymal astrocytoma? Should we be offering surgery? Should we be offering everolimus? Or should we be just watching and continuing to get MRI imaging to follow this SEGA and determine at a later date what needs to be done for its treatment? There have been attempts to kind of help provide clinicians guidance on this dilemma, and this is an algorithm that was taken from a pair of companion articles, from neurology and the use of mTOR inhibitors as a medical therapy, and from the neurosurgeons as a surgical option. And there's a lot of agreement and certainly in the recommendations that I'll show you here in a second, that if a patient presents acutely with symptoms, that surgical management by and far is the recommended therapy to go, even though there are increasing cases of even patients with symptoms being initially treated successfully with mTOR inhibitors and avoiding the need for invasive surgery. But these are recommendations that I would refer you to, and the references there are provided if you want to have a more detailed discussion and comparison from a surgical perspective to a medical or pharmacological perspective. There have been two specific recommendations coming from the TSC community, one from the Europe TSC consensus group, and then also another from the international consensus group that included both European and U.S. TSC experts. And so it's recommended that monitoring for SEGAs is needed in order to optimize treatment options. And it's been shown that if you wait until a child or an adult presents with symptoms due to SEGA, that their surgical success is significantly reduced. So the best treatment for SEGA occurs pre-symptomatically, whether that's with medication or surgery. And so age-dependent MRI imaging is recommended up until the age of 20. For reasons that we don't understand, SEGA tend to arise the younger the patient is, and so within the first 10 years of life, and including some instances even of a child being born with SEGA, is the most likely time that they present. The second most common time they present is between 10 and 20 years of age. And then it's very rare that we would have a patient present after the age of 20 with SEGA. However, both TSC experts recognize that a patient, while they may not develop a new SEGA in adulthood, it is very possible for a SEGA to arise in childhood that continues to cause growth and continues to grow as an adult. So that's an important distinction to be aware of. And then if asymptomatic SEGA from the third decade onwards, if there's documented growth regardless of its size, or there's evidence of ventricular enlargement, this requires treatment as well. So continuing the European TSC guidelines, it recommends mTOR inhibitor therapy when SEGA is in a patient older than 3 years of age, and it requires a therapeutic intervention, but it is not amenable to surgery, so they're not a good surgical candidate either due to risk or due to comorbid conditions or due to other clinical or social considerations. And there's some examples here of specific scenarios where surgery certainly would be considered a less favorable treatment option. But as I mentioned, these were followed up by international consensus recommendation guidelines, and these have been published as well, in both in their entirety, or here was referenced specifically as they pertain to SEGA, which included representatives from Europe as well as the United States, in their formation. It also included neuroradiology and neurosurgeons in the debates on what the recommendations should be. What we see here from that group is that SEGA imaging is recommended up until 25 years of age, and that MRI is the preferred modality. Certainly we can use computed tomography or even ultrasound in infants to identify SEGA. And in parts of the world or under circumstances where MRI imaging is either contraindicated or not easily accessible, computed tomography or ultrasound are acceptable. It should be noted that patients who have an identified lesion of concern that imaging more frequently than every 1 to 3 years may be clinically indicated. And again, in adults, it's recommended that imaging should be continued in adults for patients with a SEGA identified during childhood, but there was not any evidence that tells us how frequently that should occur, and so the timing or the frequency of imaging in adulthood is deferred to the clinician. For treatment, surgery is recommended for any acutely symptomatic lesions, and as I mentioned, CSF diversion or shunting is frequently required either before or even after SEGA removal. And in the case of a SEGA that's identified through imaging but is otherwise asymptomatic, then it's recognized that either medical therapy with its risks and benefits and surgical therapy with its risks and benefits are equal approaches to effectively manage SEGA, and it depends on conversations between the neurosurgical team, the medical team, and the patient and or family to determine what is the best course of action for that patient. We made a very cursory attempt to try to compare directly surgical outcomes with medical outcomes in the era of medical therapy. And this was a study that we presented at the American Academy of Neurology in 2013, which looked at 2 centers with large populations of SEGA, surgery, and SEGA therapy with everolimus and or sirolimus. And what we see here in blue are those patients treated with everolimus only, and the red we see with sirolimus only, and then we see green are patients that were treated with both. And what we see is that that there was basically comparable response to everolimus and sirolimus in each of these categories of treatment response. And that I think that the combined response of both treatments is not that these treatments were offered at the same time, but they were followed one by another, and so it's selected for patients that may show a favorable response to one over the other mTOR inhibitor, or may tolerate one mTOR inhibitor over the other, or that they were treated much for a longer period of time. It's difficult to make more conclusion for this, but I show this just to show you that in many parts of the world where regulatory approvals are not the only factor in determining access to medication, that there is evidence that either can be effective, but it should be noted that regulatory approval and the clinical testing has almost exclusively occurred with everolimus. So where do we go to next? Well, where else can mTOR inhibitors show benefit? We have definitely evidence, clinical evidence, that it is beneficial for treatment of renal angiomatomas and pulmonary lymphangioliomatosis, which have led to regulatory approvals. There are also not regulatory approvals, but certainly published literature supporting possibility of treatment for facial angiofibromas, cardiac rhabdomyomas, some of the neuropsychiatric disorders, and even epilepsy and TSC. Whether ultimately these are proven to be an effective treatment has yet to be determined through rigorous phase 3 clinical trials and evaluation by regulatory authorities. We still have some basic science or underlying pathophysiology of TSC to understand as it pertains to SEGA. We don't understand the mechanisms how subependymal nodules become SEGA. We're also in need of predictive biomarkers that may predict who has the risk of developing SEGA within the TSC population, and which of those are most amenable to treatment with mTOR inhibitors. and also to know whether there's going to be other agents that can be combined with mTOR inhibitors to have to shorten the duration of therapy, which right now for mTOR inhibitors is considered indefinite. We don't have an end point to saying when it is safe to stop treating with mTOR inhibitor if that's the treatment that is selected. There's also a lot of active investigation going towards next generation inhibitors of mTOR beyond those that we are currently using. And then we're also investigating the possibility that mTOR inhibitors may not just be useful for treating SAGA that are diagnosed after the fact, but maybe if we can identify those who are at risk or known to are going to develop, that these may have preventable roles of therapies. Again, we don't have that evidence yet, but it certainly is something that the community is interested in determining whether mTOR inhibitors might have these future roles. So I'll stop there, and as far as the evidence that's behind treatment of SAGA, and we'll move on to now some cases, and I'll turn the time back over to you, Bruce.
Thanks, Darcy. So we are going to now consider a couple of case histories. The first is that of a 2-year-old boy whose parents noticed that he's having some staring spells and unusual movements, and bring these first to their pediatrician's attention, and then ultimately he's referred to a neurologist who arranges for an electroencephalogram and in fact actually does reveal that he's having seizures. In addition, a physical exam is done, which reveals the hypopigmented macules that you've seen before and you see again before you now. And this raises the possibility that he has tuberous sclerosis complex, goes on to have a brain MRI, and this reveals some of the characteristic lesions, including the subependymal nodules and abnormal signal within the cortex. The MRI on the left shows one of the cortical lesions, and the panel B on the right, the arrows point to many subependymal nodules in this child. He actually has genetic testing performed and in fact is found to have a TSC2 mutation. Both of his parents are examined for skin lesions and are found to be free of signs, no hypopigmented macules using a wood lamp exam, no shagreen patch, angiofibroma, ungual fibromas, or collagen plaques. They also undergo brain MRI and in this case renal ultrasound, and nothing is found, and they have a negative eye exam. Even in an asymptomatic adult, it is important to do these imaging studies because a person can have any of the brain lesions, for example, or renal lesions, and be completely asymptomatic and nevertheless have tuberous sclerosis complex, and for that matter require monitoring as well as face a risk of recurrence. This child has a 4-year-old sibling who is well and has no hypopigmented macules. And in this sibling, actually, genetic testing could be performed if there's any concern about her being affected, because if she has inherited the mutation, it would certainly be the same mutation that her brother has. Well, time passes. He's now 8 years old, and he's been doing well. He's on anti-seizure medications, and his control has been good, and his development also has been good. And he's been undergoing regular MRI scans because, indeed, there is a large subependymal nodule adjacent to the foramen of Monro on the left side, shown by the arrow. And now it is undergoing growth, and he's referred for consideration of treatment. In fact, he has started on everolimus, and over the ensuing several months, it is in fact found that the SAGA does actually shrink. And incidentally, his parents report that there's been some improvement of his facial angiofibroma. The two MRI scans here show a significant shrinkage of the subependymal giant cell astrocytoma on the left at the outset of treatment and on the right after approximately 1 year of treatment. So I'm going to turn it over to Darcy for the next case.
So, thank you. And this is a case that you've seen this scan earlier in the presentation, and it'll become evident why I've chosen her to kind of share, because I think it highlights, her course highlights many of the different key points where decisions are made about what should we do as clinicians and how to manage this patient. And in her case, some of the decisions worked out well, and some of the decisions did not work out so well. So this is a 10-year-old girl who, with a known diagnosed TSC, is being followed by a local pediatric neurologist, not at a TSC center. She has significant developmental delays and epilepsy, and is nonverbal. And her mother reported for several months that she started dropping objects, which was unusual for her. Even though she was nonverbal, she could do those kind of things. And oftentimes it's a parent that picks up on these subtleties before a clinician does. But because of the diagnosis of epilepsy, and mother brought this to the attention of the neurologist, it was felt that she was dropping things because of shaky, and we're not overly concerned on part of the clinician. But mother still continued to harbor these concerns on how her child was doing, and when it progressed to the point where her child could not get up off of the floor, mother brought her to the emergency room. This was before the era of the recommendations of MRI imaging at fixed intervals, and so in this case, that this child had not had any MRI imaging for 3 years. So she went to the emergency room, got urgently admitted for an MRI, and what you see here on the right is what her MRI revealed, which was a large tumor located in the left anterior lateral ventricle with considerable ventricular enlargement, and with the clinical symptoms met the diagnostic criteria for clinical hydrocephalus. So at this point, the decision was, well, what do we do? And so surgical resection would be the recommended therapy for a symptomatic STEGA. If it was asymptomatic, treatment with mTOR inhibitor certainly is an option. And then in some cases, continued observation may be appropriate. For this patient, certainly the latter two would not be consistent with the recommended guidelines, and so appropriately she was taken urgently to the operating room for tumor removal. So she went to the operating room the following day, and there were no immediate operative complications. And you see here the preoperative MRI that you were just shown, and on the right is an MRI that was obtained the day after. And there's a little bit of layering of blood in the lower left lateral ventricle, and what you can see is that there is some residual tumor that the surgeons were not able to completely remove. This is important because this patient went home and did well, but about 1 month later, mom brought her back to the emergency room because this child was difficult to arouse. And so a computed tomography scan was obtained in the emergency room and showed bilateral fluid collections, and of particular concern was the significant epidural fluid collection located in the left frontal and parietal head region. And you can see this again manifested on the MRI, which was having mass effect on the frontal lobe. So she was urgently taken to the operating room that day for evacuation of the epidural hematoma, and recovered nicely from that and was able to be taken home. But 3 months later, a follow-up MRI was performed, and while we did not have any residual bleeding, which you see on the right, there was recurrence of the tumor from the remains of the incomplete resection. She's still asymptomatic at this point, and at this point it was offered to her to repeat the surgery and to remove the tumor a second time. But at this time, the clinical trials that were evaluating everolimus for treatment of STEGA were open, and so the mother sought a site that was a participant in that trial and started therapy with everolimus as part of that trial. And here's what resulted from that. So she initiated treatment with everolimus, and at 3 months, you see that the recurrent tumor that you see in the far left was reduced at 3 months, and again at 6 months, and at 12 months of treatment. So showing a very favorable response without significant side effects in this case. And she's been continued to be followed, and she is now 14 years of old and has been on therapy for more than 4 years with everolimus. She's had occasional mouth sores, and she's had a few commonly acquired upper respiratory infections, and she has had some mild elevation of cholesterol, all of which are known side effects that I talked about earlier in the presentation. But now you can see what her scan looks like at 4 years of continuous therapy. And at the same level of imaging in the axial plane, the SEGA tumor is almost unidentifiable in this patient. So she continues on therapy to this day for treatment of her SEGA, and mother is quite happy with the response, and particularly happy to not have required repeat surgery after the previous attempt. So that completes the presentation and of TSC and mTOR inhibition therapy for SEGA, and also highlights on how it relates to surgical treatment of SEGA. And I want to highlight the role that the Tuberous Sclerosis Alliance can be helpful in getting further information on part of the patients, as well as directing to clinicians with experience with both surgical and medical management of SEGA for patients wherever they might be located. So I refer you here to the website for the TS Alliance for further information for that, and for both your patients as well as for clinicians that might be seeking additional advice and assistance. Dr. Korf?
Well, I'll just conclude by pointing out that a lot has happened over the course of the past, really, several decades now, moving from clinical description of tuberous sclerosis complex to identification of the genes, the possibility of genetic testing, and then the elucidation of the underlying biological mechanism by which the various manifestations of TSC occur. This in turn has led to the possibility, as you've heard, of medical therapy for some of the complications, which I think is an advance that just simply wouldn't have been imagined if we hadn't understood the basic pathogenetic mechanisms of the condition. We have come a long way. I think we still have a long way to go in terms of proactive treatment and improving the quality of life, but I'll conclude just by pointing out that it's a time of great hope for patients and their families dealing with this, that a better understanding of the disorder will continue to lead to improvements in our approach to management.